The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. Welcome. Welcome to the 50/50 webinar. The 50/50 cataract webinar today. We have a plethora of panelists and a great number of speakers who are going to give us some insight into cataract and how we can deal with some of these problems that we face in cataract surgery. At the outset, I would like to start with actually thanking IIRSI and Zeiss to actually hold a platform like this, a webinar like this, where we give audiences a lot of time to talk and ask their questions, where 50% of the time is given to the audiences and their questions value and they matter a lot. I would like to begin begin the webinar with actually introducing a few members of this great panel. We have with us the chairperson, Dr. JS Titiyal, who's from AIMS. We have with us three top panelists, Dr. Namrata Sharma from AIMS again. We have Dr. Partha Biswas and Dr. John Chang from Hong Kong, who are going to give us a lot of time for their thoughts and their viewpoints on a lot of our topics. We also have four amazing speakers, maybe three for sure. The fourth one you guys can decide. One is Dr. Gaurav Luthra from Dehradun. We have Dr. Rohit OmParkash from Amritsar. We also have Dr. Chee from Singapore, and myself will be talking last at the end of this discussion. Let's start the conversation. I also want to inform all the members and all the attendees that we have three portals that are working right now. One is this web portal that you're seeing it on GoToWebinar. The second one is a YouTube page, and there is a Facebook Live page. The questions can come into all the platforms. You can put your questions anywhere you feel or wherever you are watching them. They will be directed towards Dr. Jeevan and me, and we will direct the questions to all the panelists or speakers should the need arise. Remember, 50% of the time for the speakers and the rest 50% is yours. So keep the questions going. We need you guys to know what you want to rather than what we want to say. So that's the agenda here. Let's begin this great topic of 50/50 cataract webinar. The first speaker we have here is Dr. Gaurav Luthra, who's going to talk to us about premium IOLs. Dr. Gaurav, thank you very much for being here. Take it off.
Thanks, Ashwin. Thanks, Dr. Titiyal, and a very good morning to all the chairs and all the speakers and to all the listeners and the viewers. So I was asked a difficult topic to speak on in 7 minutes. That's premium IOLs, which is like, we should probably be writing a book on that or, have a full day to discuss. But I'll try to make the best of it. And I think what the talk was intended was to kind of introduce where we stand as far as premium IOLs go and what are the options and why we should be adopting them if we haven't yet adopted them. That's what I'm going to limit myself to. And is my screen shared, Ashwin?
Yes,
is there.
I'll just try to see it. Yeah, okay. So can you see my presentation now? Is it in the full screen mode, Ashwin? Okay,
yes,
great.
Yes,
So I was going to talk about premium IOLs, and so I have no financial interest. Let's see, we all understand that how IOLs first came into being with the chance discovery by Harold Ridley with that PMMA thing going into the, eye and being tolerated. And that's where the first lens started almost little less than 100 years back. And we've come a long way. And why should we be talking today about premium IOLs in the first place? What has changed over the last 50, 60 years that today we are talking about premium IOLs? And frankly, what are premium IOLs? So I think what's really changed in the last 20 years is patients' expectations and quality of life have changed. And refractive surgery procedures like LASIK and SMILE and ICLs, hyping freedom from glasses, have shaped the expectations of cataract surgery patients as well. So in emerging countries and in the developed world, the paying capacity of patients has allowed them and given access to better and premium procedures. So they're willing to kind of spend a little more, just like they spend on their phones. And patient expectations, frankly, have changed. So they include higher success rate. They want lower complications. They want excellent, uncorrected visual acuity outcomes. and they obviously want reduced dependency on glasses in various activities, and that's where premium IOLs come in. So cataract surgery, cataract surgeons categories can be redefined now. So there is the old school cataract surgeons or the traditional cataract surgeons who are content with what they are doing. They do not really worry about reducing the dependency on glasses. They are just happy to get a good looking eye and, a nice IOL in the bag, and, happy with that. They would mostly be implanting the monofocal IOLs, and they may not be so keen or receptive to newer procedures or technology. They are happy with what they are doing. And then there is the other category of the refractive cataract surgeons who, let me just minimize this one moment. I think my slides went away. Okay. So the refractive cataract surgeons who are very, very keen about astigmatism correction, they look into that very keenly, offer a range of cataract procedures suitable for different patient categories. They may also be co-performing LASIK or SMILE, or maybe not. Most cataract surgeons would probably be doing their cataract surgery with this refractive aspect in mind. And then there are the multifocal IOL experts who have been very keen on the new types of multifocal IOLs available to us, and they're pretty happy to explore the newer technology and procedures towards getting happier and happier patients. So with that in mind, the evolution of premium IOLs over the years, the types of premium IOLs that I have used in my practice over the years, and here I'll limit myself not to the monofocal premiums because there is a range of premium monofocals now, but I'm going to restrict myself to other lenses. So we started off with the Sion kind of multifocal PMMA lenses way back about more than 20 years back, and went on to the twin set, which was from Acrylisa, which was subsequently acquired by Zeiss and taken way further with the new platforms. And then the the spheric and then the aspheric multifocals, the accommodating lenses which came in the way and which eventually could not really accommodate. And then we've had a lot of lots of bifocal lenses with different ad bars, and we've evolved from the high ads to the low ads over the years. And then we went on to the extended depth of focus lenses, and today we are also into big way into trifocal. So that's a long way to go. And what have we learned along the way? It has taught us a lot about the visual functions of all the IOLs. So we know a lot more today of how these IOLs work and how patients accept them. We've also learned how to manage them and how to give quality outcomes to different patients, and how to add these IOLs to your practice is key to remaining competitive and differentiating in the modern world of refractive cataract surgery. And it's very important to manage patient expectations very well as well. So a happy, satisfied patient is probably the best word of mouth advertisement for a practice, besides what you can achieve with social media and other advertisements. So nothing to beat word of mouth. Now, what's the doctor's role and responsibility in this? Function of the doctor is managing the disease pathology, operating on the cataract, the surgical management of visual function. But patient expectations have to be met because they think that we can solve 100% of their problems, which may not necessarily be true. So what's the solution? Understand the patient's needs, set the right expectations, and deliver the right result by choosing the right procedure. So where to start? I think first thing, if you are not already doing all this, if you are wanting to be a refractive cataract surgeon or want to evolve as a refractive cataract surgeon, raise your standards, perfect your biometry, start getting 90% of your patients within plus minus half of emmetropia in your outcomes, pay good attention to astigmatism, do a toric calculation for all your patients, even those with just a 0.5 cylinder, because you'll be surprised by some of them who might still need a toric IOL. So happy emmetropic patients will refer a few more, and there is a large choice of presbyopia correcting IOLs now. And let's go on how we can do this. So tackling astigmatism, I won't go into the details, but one slide to tell you, measure it well. Use all the devices available in your clinic to measure. You may have at least 2-3 devices, an autokeratometer, a handheld, a manual keratometer, maybe a topographer, maybe optical biometer. You might have one of the Callisto or the Virion kind of devices. You may have an iTrace or another abrometer doing that for you. So look for consistency of measurements. Typically in my clinic, each patient who goes for cataract surgery has 4 or 5 measurements for the keratometry and an optical biometry for sure. And that helps us decide. And now we of course use the abrometer as well, but it's not necessary to get good outcomes. So do a toric calculation for all your patients. And then when you treat them, I think everybody might agree that toric IOLs now today are the most predictable way of correcting them. So don't hesitate to use a toric IOL. Of course, there are the other ways. You can do the arcuates, you can do the femto LRIs for small astigmatism. You can make steep meridian incisions. You could do opposing clear corneal incisions. You could do what you want. But for me today, toric IOLs probably are the best way, and we have a huge range of toric IOLs available. And today's ICE is doing this symposium, but I use all various company toric IOLs, and they're all great. I like the Zeiss ones. I like the ones which come from J&J, from Alcon, and even the Indian lenses today are excellent. So do them, but learn them well, and try to get all your patients, I typically tell my toric patients that we are going to try and bring you below 1 so that we don't have the wrong expectations. We typically achieve a 0.25 or a 0.5 plus or minus. That's 90% of our patients. Now, correcting presbyopia and understanding your patient, introduce the possibility to every patient who's coming to your for cataract surgery, from your waiting area for patient education, leaflets, from your counselor to the doctor's room. Just let them know that there is a way that you can see for near without glasses. Build up the expectation, assess each patient's needs, give full chair time, give a patient hearing, and understand the mindset of the patient, the occupation of the patient, what his needs are. Clear the myths and misconceptions. Sometimes when we try to introduce this topic to a patient about presbyopia correcting lenses, and the patient say, oh, I don't want to do a multifocal. You might get turned off and say, okay, this guy is not good for multifocal lenses. But I think it's a good way to ask them that, why are you against this? Try to understand. Maybe he has a friend who has had a bad outcome for some reason which he doesn't understand. So try to clear the myths that, patients may have in their minds. Explain how variant needs may evolve post-cataract surgery. See, some patients who are currently myopic because of the cataract, they may be reading very well. So it's very important to tell them that if we go for a monofocal lens, for following surgery, you're going to need glasses for seeing your watch, seeing your phone, reading everything, because they may not understand that what's going to change after surgery. So please take out 2 minutes to explain to them life after cataract surgery if we are doing a lens with a monofocal or a presbyopic correcting lens. Now, a thorough evaluation, I think I will not go into details at all. Ocular surface, tear film, and very accurate biometry, an astigmatism management plan. Look for coexisting pathologies, a good retina exam if you're doing multifocals, OCT of the macula if possible. If possible, do a topography and aberrometry, but they are not necessary. Other considerations, look at the pupil size, very important. If somebody has a really small pupil size and you put in a lens which has a big central area, the multifocality may not work and may be counterproductive. Look at the patient's arm length. See if he has long arms, so we might want intermediate vision. Look at if he has short arms, or a lady who has short arms might be happier with a multifocal or trifocal lens. Look at the corneal sphericity and try to balance that out. Now, each of these topics requires a full presentation, so I won't go into the details. Look at night driving requirements, the personality type. Look at the profession of the patient and plan your lens well. Look at the age of the patient, whether it's a young patient, unilateral surgery, bilateral surgery, whether there's any history of previous refractive surgery. That will help you decide what kind of lens to choose. So I will not go into the depths of this chart, but visual functions are multifaceted and involve so many things. So patient perception of vision being one very important one, and the contrast sensitivity. So choosing the right IOL for your patient, a range of IOLs is now available, and for different needs. One size does not fit all, nor does a lens. There are so many choices: monofocal, monovision. You can have an extended depth lens with monovision. You can have an extended range of vision IOL, bifocals, trifocals, mix and match. So choosing the right procedure is equally important. You could do a Phaco or a Femto assisted procedure with LRIs. You could do incision planning, toric multifocals. So counseling and setting the right expectations for your patients is so important. The counselor's role is to set the right expectations. So is the doctor's role. Never hype total freedom from glasses for all activities. Tell them that you may still need glasses for occasional work. Discuss about the best results when both eyes are done together. Mention about glare and halos, but don't talk too much about it. You just let them know that almost everybody gets some of them and they mostly go away in 95% of our patients, and educate them well. Pick the best candidates for your surgery and pick out the red flags. In our practice, we started multifocals in 2002, torics in 2008. In 2010, just 3 to 4% patients were getting multifocals or torics, and only 70% were plus minus a half for their refractive result. In 2012, we acquired an optical biometer. By 2013, 85% patients were plus minus half. We had 10% practice of torics and 10% multifocals. Today, torics are 30%, multifocals are about 20% of our practice, and another 5% are multifocal torics. And our distribution of multifocals has changed completely in the last 2-3 years, with a big skew towards the trifocals. Almost 80% patients are trifocals, very few bifocals. And I see that bifocals will probably go away. We'll stick to the trifocals because of their excellent results at the 3 ranges and patient acceptability and lesser incidence of glare and halos. Last slides. Dissatisfied premium IOL patients, you must watch out for them. Don't kind of disown your patients if they come back dissatisfied. Look at the causes. Could be astigmatism, residual refractive error, could be the wrong expectations set by us. Please discuss with them. Binocular vision can be a problem. near difficulty, they may find difficulty reading, ask them to use good illumination. Difficulty with distance vision has to be sometimes looked at. Glare and halos may be a problem. So how to manage them? Again, a full topic, so only one slide on this and then I finish. Patient hearing to your patients is very, very important. Empathize and reassure. Make sure that you understand them, listen to them, and reassure them. Don't tell them that, okay, this doesn't happen, or even telling them that this happens to every patient can put them away, because they may not come back to you. They may get totally disheartened and think that nothing can be done about it. So tell them things can happen and we can improve upon it. Look for the potential causes. Counsel about neuroadaptation. Don't lose your patients. Keep talking to them and trying to bring them around. They will, 90% of them will settle down. Maybe do an abrometry if they are not settling down. Try to find a cause. Advise fusion exercises and try to divert the patient's attention from this dissatisfaction to other things. Try to divert them to their fixation to other things. It sometimes helps. So ensure the attendant also understands what you're trying to tell them. And as a last resort, this is really important. Give them that option that we can expand this lens and very nicely give you a monofocal with excellent distance vision, but that you're going to start using reading glasses. Some of my patients never came back. They said, okay, we'll manage like this itself, and we are happy. So what's the take-home message? Cataract surgery has evolved into a refractive cataract surgery. Patient expectations for freedom from glasses after cataract surgery have grown a lot. A wide range of IOLs is now available to meet the needs of the doctor and the patients. Diagnostic modalities have kept pace and evolved to get close to perfect outcomes for us. We have better understanding of newer lenses and patient point of view, and surgical techniques have come a long way to help us. Good counseling and chair time are the key. Also, last point, post-COVID slowdown, I think it's a good time to move into refractive cataract surgery if you haven't, or to take it to the next level with premium IOLs, because you'll have more time, you'll have less patients, and you're probably going to try to look for better outcomes. Thank you so much, and I think I'll stop sharing my screen. I'm happy to.
Thank you, Dr. Gaurav. That was excellent. It was such a precise and to the point conversation on premium IOLs. Before I move on to questions from Dr. Jeevan and me will ask the panelists, I think it's important to tell all the audiences, if you have any questions, please put them up on the question list in the GoToWebinar, or you can also put them up on the Facebook and the YouTube live comment section, and we will get all the questions to answer them. We have a lot of time to answer questions now, after each conversation, as well as post all the topics, post all the speakers. I have a few questions that have come. We'll start with one or two, and then we'll take the next topic. So Dr. Rohit, if you can prepare your slides up for the next presentation.
Can you allow me to be the presenter one? Yeah.
Okay. Now, panelists, Dr. Partha, if you can just let us know. Somebody's asked a question. What if I don't have an IOL master, or I don't have these premium products? What do I do in those cases to calculate for premium IOL specifically? I want to give my patients the best result, but what should I do?
Right. So very, very valid question, because all of us definitely want to give the best outcome to our patients. But remembering the fact that the best outcome, as Gaurav so rightly said, depends upon the accuracy. So the accuracy of all the parameters is so important that at the overview, when one is planning to switch from the normal IOLs to the premium mode of IOLs, everything, the workup should be done so that even if I do not have a particular equipment, it must be available in my locality where a patient can be referred, get the topography done or get the IOL master done, and the optical biometry and if required, the abrometry and the topography definitely needs to be done. 100% the OCT needs to be done if the patient does have clear media and good enough media, and these are absolute good parameters. Otherwise, the problem would be, the blame would come onto the lens and not on the inadequate pre-operative workup that has been, which again translates to us as surgeons. So I think a proper workup has to be done if one is planning a premium IOL.
Fantastic. Dr. Chee, actually Dr. John, if you are here, if you can answer one question. In case of old LASIK patients, do you choose premium IOLs or no? Is a question.
Yes, I do. You know, with these optical biometry, they're really quite impressive. And the newer formulas, In fact, Barrett has even a toric formula. So not only am I putting in trifocals, I'm putting in trifocal torics, and I'm getting very nice results. The new formulas and all the optical biometries is quite impressive. And with the newer lenses, they're quite good. I think that with the post-LASIK, a lot of times the problem is the glare more than the halos. And with the newer lenses, we've actually really avoided that quite a bit. For the higher myopes, say about 8 diopters or above, I usually just use an EDOF, like the AT Lara, or the weaker ones. But for the lower myopes, 6 diopters or below, I use the full trifocals. They work very well.
Fantastic. Thank you.
Yeah.
Ashwin, I'd just like to add one thing. Ashwin?
Yes,
what
please.
Dr. Partha talked about, referring the patient to a place where you have devices. I think with economy going down and next few years, it will be tough for all of us. I think the group practice and sharing the clinical area would be the future, and that will make sure that you have the best equipment for a group of people. I think that should be the thinking of younger generation rather than trying to acquire everything for themselves and difficult to maintain. So I think group practice will be the future.
The only problem is if you refer the patient to some other place, then that some other place will only do it and will not send the patient back to you. Because
that's right, the group practice has to be there.
Then he's capable of doing a premium IOL himself.
That's why they have a pooled thing, group like Partha knows the thing, and that should be the future for the Indian practice.
I think
thank you, sir.
I think what Dr. Jeevan is that collaboration is probably the way forward, and how you can mutually exist is something that we have to look at in the future. If I may be right in summarizing that.
Yeah. Ashwin, I would like to add that, we never had all these devices, and we've been doing premium IOLs for 15 years. It's just that we got better. So the take-home message should not be that you must do these things to get a good outcome. Even if you don't have an optical biometer, but you can invest a couple of lakhs into a small, better keratometry device, get a good ultrasonic immersion scan. You can still do it. But of course, the newer devices make life much easier and better. Yet you can still achieve 90% good outcomes even with very basic devices, should be the take-home message, so that it doesn't discourage our viewers who don't have these devices that they cannot go on to doing these things. I was still doing torics when I did not have an optical biometer. It's just that, I did them much better subsequently. So when possible, do add some of the basic devices. I think an optical biometer is a must once you can afford it, as important as a phaco machine or in microscope. Yet it's not compulsory to have it to do all these things. Yeah.
I have a comment. Can I say?
Yes.
The water immersion actually works quite well. They're quite accurate if you don't have an optical biometry. And if you have that, maybe start off with the EDOFs because they're more forgiving. If you're a little off, they're more forgiving. They tolerate up to like 1.25 diopters of astigmatism, whereas with the trifocals, they only tolerate 3/4 of a diopter. So you can start off with the EDOFs and use water immersion and get a feel for that. And maybe, hopefully, you do enough cases to make enough money to buy an optical, aberrometer or biometer.
Fantastic point, John. Before I move on to Dr. Rohit's talk, one last question to Dr. Namrata. How many of the regular patients, Doc, do you do to do topography on them? Because in regular patients, even if you don't have a premium, how do we know if there's an amount of toricity to the cornea and we have to combat that pre-op? Do you do in regular patients as well, topography, or no?
Regular patients we don't do, only when we are, we see in the IOL master that there's some degree of astigmatism, and sometimes you need to correlate, get the correct axis or the correct amount of astigmatism. Only in those cases we do topography, not for all cases.
Fantastic. I think thank you so much, panel, for helping me in this. Dr. Rohit, if you can start off your topic on intermittent cataracts.
Can they give me access for the presenter?
Yes.
Yeah, show my screen. Yes. Yeah. Am I on?
Yes.
Is it okay?
Perfect.
First, all, I would like to thank Dr. Ashwin for coming out with such a stupendous symposium. All of us know that Ashwin is a gem in ophthalmology. He has given me the topic of intumescent cataracts. Well, these intumescent cataracts have the biggest challenge while performing capsulorhexis, because more often than not, each one of us have ended up with an Argentinian flag sign. The diagnosis of a fluid-filled pearly white intumescent cataract is somewhat made out by the thickness of the lens, which increases anterior-posterior, which can go right up to maybe 5 millimeter. ACD is subsequently decreased. Slit lamp examination helps. Biometry can help because between the L1 and L2, we have 2 or 3 spikes. And OCT, as Dr. Abhinav Dhami has shown, that we find fluid-filled pockets on OCT images. So anterior segment, those can also help a lot. You know, we have to understand a few basic fundamentals. First is that there's a high intralenticular pressure, number one, and some percentage have 3 compartments, quite contrary to the Morgagnin or the other ones. You can see that there is an anterior and there is the posterior one. This is the anterior and the posterior compartment. So these compartments have contribute separately to the rise of intralenticular pressure. Then the posterior pressure has also to be sorted out. So this posterior pressure is in the form of, you know, we can decrease this by giving mannitol. You know, if by chance I don't use block for that matter, but if you're using, use Hyalase to spreaden out that. And as Chee very often has said, that, you know, she's coming across patients where exposure is different. So, you know, the Jaffe speculum really helps a lot. So Jaffe speculum is another important thing. As far as the anterior chamber pressure is concerned, well, we need to take care of that. We need to increase and equalize the pressure in the anterior chamber. A viscocohesive, for that matter, is obligatory and mandatory because it goes in a long way in increasing the pressure in the anterior chamber so that it becomes equal or maybe higher than the intralenticular pressure. What is the plan now? Well, if the anterior chamber depth is less than 2.3 millimeter, my preferred technique is to use a 30 gauge needle aspiration, wherein the 30 gauge needle goes in and aspirates. So in this video, you will find that there is, you know, it's already triconvulse stained. The 30 gauge needle goes in, visco-cohesive is very much in, and the outer lip has some visco so that it doesn't come out. The moment you go in, that is the time when simultaneously the aspiration has to start. You can go with either bevel up or bevel down, and you will find that here that it has become a concave structure in the center. So with this in mind, now what is the next situation? The next situation is that in the center, what has happened is that there is a concave. So here the pressure is less intralenticular, but the area which needs to be sorted out is this area and this area. Now, what do we need to do now? So first is, don't go to that, you know, the mid peripheral area. How do we do that? We create a small rhexis and complete it, and that too in the central area. Or, you know, if you have to make the incision, make a micro incision, if possible calibrated, and a partial micro incision, as Dr. Arun Jain from PGI has shown all over how he does it. See how I'm not going fully in, and with the micro forceps, because you do not want the pressure in the anterior chamber to decrease by any means. So once that is done, life becomes easier. Now, if we have to, in cases wherein the anterior chamber depth is more than 2.3, I prefer to use a micro incision and a micro forceps for that matter. But the most important thing is, you know, we have to give the direction to the initiation, because if we don't give a curved direction, there's a propensity of it to go to the periphery. Next important thing is, which we have started doing now, is the reverse angled initiation. Now, what is this reverse angled initiation? You pull it towards yourself. See again, you pull it, puncture it and pull it slightly towards yourself. Now, how does this help? See how it will help now. When we create a reverse nick, it comes directly under your excess. Even if you are trying to, struggle around, it is directly under you, and you can very well complete a small rhexis by that matter. You can see now how, the capsule is bouncing. This shows, by all means, as Dr. Chee always says, see the bouncing, and that will let you know that it is an intumescent cataract for that matter. Next, again, because Chee has done so much of work, I cannot but salute her for so many things. Next thing which she does is, which can be brought into practice, is the cortical milking. What do you do in cortical milking? From the mid periphery, you squirt out the fluid towards the center so that the mid periphery doesn't remain the red zone. It comes into the orange zone in the COVID terms. So next is debulking and decompartmentalization. What we do is, we want to do this taking into care the Brazilian, so that there are no two compartments, the anterior and posterior. And at the same time, you are aspirating it. You will see how it is being done. You use the side ports to your advantage. When you're using side ports to your advantage, you're pushing and the nucleus also, and which creates a fluid, which allows the fluid from the posterior compartment to come to the anterior segment, and we are able to take care of that. Now, once all this is done, the CCC can be enlarged to even such a large, 2.8 millimeter incision for that matter. So you can see how easily, with all central and mid peripheral, the pressure taken control of, you can easily complete a rhexis for that matter. Yes, we have been using preoperative YAG laser in quite a few cases. That can be done 30 minutes before surgery, and you can use Diamox also, because at times there can be some bit of rise of pressure. And because the fluid, when it comes out, the intralenticular pressure decreases, and see how easily you can complete the rhexis, irrespective of the fact whether it was an intumescent cataract for that matter. The great Mohan Rajan, Panchorhexis for that matter. He has been using it. I have tried it and I find it's good, but somehow it has not taken my fancy. You have to use a longitudinal one, no nozzle for that matter. A 0 degree tip has to be used. And if you are successful in creating that, you can complete the rhexis without any problem whatsoever. Next is, at times we think that it is an intumescent one, and we find that, we are easy and we can complete the rhexis. Then you can spiral it around. So this is a very old video, and I've been doing spiral where I find that, it is not really intumescent with the cortex fully liquefied. So the basic fundamentals involved are, you reduce posterior pressure, increase anterior chamber pressure, decompress central area, create a small rhexis, reduce mid-peripheral and posterior compartment pressure, and complete the rhexis. Well, let's see some pearls. Reverse anterior opening. It is trying to extend, but since it was directly under my view and my scope of controlling things, now where do we put the visco? You put the visco where I put, so that it doesn't extend, and then you can complete the rhexis in this intumescent cataract for that matter. Why did Argentinian flag sign happen here? Well, the patient was squeezing the eye. It was not a micro incision. A viscodispersive was used, and non-calibrated incision was basically the cause for this. Well, despite this, we can still end up with an Argentinian flag sign. Well, if the flap, I'll make it very short, if the flap here is fluttering, as you can see those stripe-induced stained flap, if it is fluttering, it means it is pre-equatorial. And if it stops fluttering, this means it is post-equatorial by all means. So post-equatorial, it means you have to convert for that matter. Now, with this flap motility sign, you can see now it has stopped fluttering. So this means it has become a post-equatorial. The surgeon continues. So we can know the site of IOL implantation in these intumescent cataracts with Argentinian flag sign. An intraocular lens with fluttering, you can put an intraocular lens in the bag. The end point of safe phacoemulsification we can also know in these cataracts. When the moment it stops fluttering, that is the end point, and is that because this appears much before the classical signs of posterior capsule rupture. Infamous manifestation, well, you really do not know what to do. When you put in the visco, in a good percentage, you will find here that the flap has become everted. but it becomes 100% manifested the moment you introduce fluidics. You will see how the fluidics are introduced and the flap has started fluttering. So with this done, then we at the same time we have to go in for the safe vacuum-emulsification technique. Site of incision is important, low fluidics, stable chamber settings, reduce separational forces, reduce rotation, direction of separational forces in the direction of tear, and use a supracapsular opacification. This is a very short video, and you will find that I'm not trying to separate more, using stable chamber settings, not going 90 degree to the plane of the anterior capsular tear for that matter, and you will find how the capsular axis will be completed. With the flax, that has really helped a lot. You can see this volcanic eruption. So this helps a lot. So in intermittent cataract, they have their own role. Here you will find what is there is that even with the white cataract, there is fragmentation. And you do not use the pinching technique. Here we take the benefit of doubt and go all around with the trypan-blue stain. Here you will see what is happening is it's almost fragmented. So this fragmentation is become so simple and so easy to perform, but that doesn't mean that if you don't have flax, you will not be able to do, because with the techniques which I have explained, there is hardly any incidence of Argentinian flag sign for that matter. So the last but not the least, if the plan doesn't work, change the plan, but never the goal. Thank you very much for your kind attention.
Well, thank you so much, Dr. Rohit, for that amazing presentation. I think every little aspect and detail was mentioned there. Dr. Jeevan, any words before I go into questions?
I think Rohit has described beautifully how to tackle the difficult situation. And what I foresee in this lockdown period, you will have more such patients coming up in future, and they'll have to be taken care of, more of such cases. But yes, apart from doing all those techniques, what we have described also, what I do personally is do an intra-op assessment of all cases with, if you have a microscope which has an OCT attachment. So you can see the entire dynamics of a capsule, which Rohit beautifully described, the pressure induced by the viscoelastic, how the flattening occurs, what type of hydration of a cortical matter or a cortex which is behind the capsule, then you can plan your surgery accordingly. So that anti-segment OCT can also give you those details. If you see my publication, JCRS now it's online. The entire thing can be delineated. You have various types of intermittent cataract or raised lenticular pressure, and you can design your surgery accordingly, which Rohit has described each technique beautifully.
Fantastic.
I read your paper in JCRS. That was too good, Dr. Jeevan.
Yeah, I think that was awarded also by the American Academy of Ophthalmology as the best video, and that gives very clearly, that why in some cases the fluid just exudes out and why in other cases it doesn't. And if you can preempt beforehand, and I don't know, I think sir can comment on that. Can anterior segment OCT, which is a high definition and not intraoperative, be a good substitute for pre-op evaluation of those kind of cases? At least you will come to see the.
Yeah, definitely, it can delineate entire picture, as you can see in intraoperative also, and you can plan your surgery accordingly. Intraop only, it tells you how much pressure, how much flattening the capsule occurs after release of a fluid, what happens to the capsule. Those can be seen better. Otherwise, if you have a good high definition anterior segment OCT, that can give you a beautiful picture and then plan your surgery accordingly. You can choose your steps also.
Thank you very much, Dr. Jeevan. Going to some questions, and meanwhile, Dr. Soon, if you can also have your presentation ready, we'll go with a few questions. Also, just remind.
Sorry, I can't share my screen because I think there's 6 people on the webcam.
Yeah, okay. They'll give you the access.
So I have paused.
Thank you.
Yeah.
So just to summarize,
audiences.
Yeah, they'll give you the access, Dr. Soon. To the audiences, please put in your questions, as many as you want. I know I'm getting a lot of them on the side, so keep them coming. Some questions is the Madam, Dr. Namrata, this is actually towards you. Is femtosecond a good technology to use in these intermittent cataracts, and how do you do it? What is the plan of action over there? So
I
if you can
think
just
it is a great tool to have, especially for white cataracts, because it does prevent the Argentinian flag from happening. And I think there's an article which again Professor Titiyal sir has written on femtosecond cataract guided femtosecond cataract surgery in white cataracts. So you can precisely tailor your the size of your rexes without actually, having it doesn't get extended. That is the most important thing.
right,
Even if intralentricular pressure is high. So it is definitely, it has a advantage over conventional technique that you do.
fantastic. Dr. Partha, if you can answer this question, how do you know when to stop pulling on the rexus maneuvers and start cutting with scissors in case these become fibrotic? Some of these cases come up as fibrotic, and in those cases, how do you? I mean, I think it's a very interesting question, but you can just tell
It's a
us
very,
what
very
maneuver.
interesting, important question, because the fibrosis in per se in the anterior capsule in one of these intermittent cataracts can be very, very mystifying, because it might not be very visible while the slit lamp by microscopy is on and preoperatively. So it is usually when the stain is there and one realizes that the rexus is not moving and there is a fibrotic element in the anterior capsule. It is at that point of time, without pulling at the rexus any longer, to come from the side port and snip that part of the capsule which is fibrotic. Then going again beyond the fibrotic area, again with the forceps or with the micro forceps, and here the micro scissors as well as the micro forceps both hold a lot of promise and should be done. So up to the whole limit of the fibrotic element has to be snipped. At times the fibrotic element can be large, and thereby you have to go from the either side and snip, so that you are not actually pulling on the fibrotic element, because a fibrotic element can never be pulled and it will either run off to the periphery or the zonules might get detached.
Fantastic. Okay, thank you, Dr. Partha. That was fantastic. That was great small tips which are going to really help a lot in actual surgery. Dr. John, could you answer one question which I think is very interesting? If an Argentinian flag sign does happen, I think it's a two-part question, and I'm just going to say it the way I understand it. If we have an Argentinian flag sign, do you still put in a premium IOL? One, and second is preoperatively, do you even counsel for premium IOLs in these cases?
Yes, I usually say, there is a chance of that Argentinian flag. I would definitely use the Femto, because the Femto definitely decreases the chances a lot. And I said, no promises. I'll do my best. I'll try. And it's worked out very well. I do have, if you don't have the Femto, Dr. Prakash actually had a very good thing. When you're doing the CCC, you can do it like a reverse traction. They do that, the pediatric ophthalmologists do that. So they make the CCC pulling actually in the opposite direction. And that actually much better, much less likely for that CC go out and become Argentinian flag.
Right. Okay, that's it. I think these are the questions for now. We'll move on to the next presentation. Dr. Soon Phaik Chee will be talking from Singapore. Dr. Soon on small pupil. Go ahead.
Screen now? You can see my screen.
Yes, full screen.
Okay, so sorry, I don't know why it's okay. So some causes of small pupil commonly seen: diabetics, uveitis, people on drugs, elderly. And so when we see a patient with a small pupil, we look out for posterior synechial, posterior peripheral anterior synechial membranes. And in this case, we don't have any. It's just a small pupil that's not adherent. We have to stop the anticoagulants to make sure we longer corneal tunnel. And you can see in this case here, the iris is also very, very floppy. And this is not uncommon, especially when we deal with diabetics, although this happened to be a uveitic patient. And as you go along these irises, they cause lens iris diaphragm retropunction syndrome, like what we're seeing here. And you can see the iris really going from large to small. So perhaps, doing this case without the aid of some hooks or a pupil retainer was not such a good idea, all right? Although I thought that we could still complete this case quite safely. Now, if you have a small pupil, you can always start off by intracameral adrenaline of this 1 in 100,000 dilution, give lignocaine 2% preservative-free. And then if the pupil dilates but not adequately, we can just use some viscoelastic. But in this case here, it's adherent. And I like the Coughlin hook because the push and pull hook, which can push away all these adhesions. At the same time, you can also use it to pull, to release the adhesions, and not just at the pupil edge, but also over the broad posterior surface of the iris. And then I like to remove these membranes so that the pupil can dilate evenly. And if that's not adequate, you can use 2 Coughlin hooks to gently, carefully retract the iris in opposite directions, but not towards the incision. I'm going to show you the use of iris hooks. This pupil is really small. I've already unbound the pupil by releasing the posterior syndicate here. And look at the position of the paracentesis. They are in a diamond form, subtendinally and across. All right. So this is taught to us by Thomas Oeting, who suggested that the best position to actually have the hook is really under the subincisional area so that it does not get chafed against the phaco needle as we do the phaco. And you can see here, this pupil is starting to, when I try to expand it a little further, it starts to rip here. And so I'm a bit worried because this is a chronically inflamed iris and it does not stretch nicely. All right, there's fibrous tissue and that doesn't stretch, unlike muscle. So in this case, this is the time to do sphincterotomies, and just small ones, just at the sphincter, so that the pupil can still remain reactive after the surgery, and the pupil will still remain round. And you can see we slowly titrate the size, we can adjust the size, and that's the good thing about iris hooks, because you don't have to stretch it all the way out. You may not need such a big incision. As you saw, Rohit also mentioned that micro incision, which I used here so that the iris wouldn't give me trouble when I start to manipulate. This is the end. You can see a nice round pupil. Now, if you had forgotten and you had created a square kind of a pupil, you can always add this 5th iris hook, which comes in the pack. Right, just sub-incision, you have to go a little more vertically downwards. If you see a membrane, you can see a PI created here. This was totally occluded. I used just a Kawai forceps, which is micro forceps for capsular access, and I just pick very carefully initially at the edge of the pupil, and then once you lift off the pupil, you then grab the membrane. All right, be very careful what you're grabbing so that you don't grab and tear iris. There may be a bit of bleeding, but that's okay as long as the patient's not anticoagulants. And then you can snip off these frills so that you have a nice round pupil at the end after your surgery. I'm going to show you the use of a Bila pupil dilator, which is something which you can reuse for each case, and the patient doesn't have to pay for the additional cost of a device. So this goes through a 2.6 mm incision, but we have those that go through 2.2 mm incisions that are multiple Coughlin hooks, which you insert into the eye very carefully, and then they come out in a fashion that you'll see looks a bit triangular and awkward. So you're putting all these Coughlin hooks on the edge of pupil. It helps to put just some viscoelastic underneath before you engage the hooks. All right, and it looks strangely triangular, but you will see once you put in the OVD, the pupil actually expands very beautifully and is round and is a good size. All right, and you don't need other devices. I'm going to show you what I commonly use: a pupil expander and a retainer, which is a Malugan ring. Unfortunately, I do not have the BHEX available to me in Singapore. So you can see here, I'm just removing the membrane as I always do, so that with a Malugan ring or any other pupil retainer, it actually becomes round. All right. If you don't do this important step when you put in a Malugan ring, you'll find that the ring is not centered the eye. So it helps again to put some viscoelastic under the pupil before you do this step. And I like to retract the iris near the subincisional area with the iris Coughlin hook so that we do not have to push this device into the corner just across. And this is at the end of it. Again, this is a little tricky. You need to release it, retract it, and compress the 2 rings. And as it comes out, be careful because the Asian iris can be rather thick. and get retracted by that last ring. Now I'm going to show you a smaller pupil. That was the first version of Malukin version. The first version thicker, the ring or proline, but in this case here, it is made with 5-O-proline, so it's thinner. It can go through a 1.8 mm incision. Use a 6.25 mm ring rather than 7 mm ring for these small pupils. Now you can see here, its patient has got a band keratopathy and it's difficult to see clearly. This is retracting the ring. Please do not pull up the injector without retracting the ring first. And you can see it can be a little difficult to get this on because pupil was so small, right? You may need a second instrument to help. And again, it helps to have a cochlear hook retract the iris. And you can see here, getting on the final ring. So don't be disappointed if you can't get them all on simultaneously. You can do them one by one. And then finally, again, retracting it, compressing the two rings as they come together and releasing that part of the iris before you pull. Now I'm going to show you a disaster with the Malukin ring 2.0. So this again is a really small pupil, and I like to zoom up really to high magnification so I can see what I'm pulling. Whoops, I pulled a bit too much, and that was a posterior pigmented leaf. All right, so be very careful. So again, I'm trying to release any kind of posterior synechia and put in some OVD just under the pupil. Now look at the ring go in and the pupil size. And this you can see is a very flexible ring. It doesn't always obey you, right? So this is the 2.0 version of Malukin ring. It's still a 6.25 mm device. It expands pupil to that size, but you can see I'm struggling to get it on. Now fast forward it so that you don't have to see me struggle so much and for so long. All right, so I finally got that on, and I'm struggling with the final one. Oh, what am I going to do? So I use forceps and a cochlear hook, and that really helped to get this on. And finally, it was fine, but I struggled. So you should have raised hooks, I said to myself. That would have been much easier. Now, at the end, you've had a small capsulorhexis, and the pupil expands much better after the hour ends. Please expand the capsulorhexis. So always release peripheral anterior synechia before posterior synechia. Always make sure that you use a device that is suitable for the size of your pupil. And thank you very much.
Dr. Chee, that was fantastic. Thank you so much. It's fantastic.
Thank you.
Amazing.
Again,
Amazing.
if you still have questions, audiences, please send in your questions. We are still getting a lot of questions, and I'll keep them going. Dr. Jeevan, do you have any comments before I go into the questions more?
Well, I would like to put a question to Dr. Chee. How do we decide which particular case would you like to use iris hooks, and which are those cases where you like to have expanders? Do you have some sort of a definition, which case, what type of procedure should be done?
Okay, so definitely, you know, if you are not a frequent user of the Malukin ring, right, you don't want to try on a very, very small stuck pupil, because as you saw the disaster, even though I've used so many of these devices, all right, it can be really very, very difficult to do this with a Malukin ring in the small pupil. Now, some of these irises do not stretch well, even if you have released them from the synechia, and so don't use a Malukin ring. Change to iris hooks. If you have very shallow anterior chamber, the Malukin ring takes up space. So you also want to use iris hooks. And of course, if you are worried that the iris will not be able to dilate nicely because it's been chronically inflamed and there can be fibrosis, then you use, again, iris hooks, because it's very good in that you can titrate the size of the pupil. You can slowly expand it bit by bit. And, you know, the Malukin, the iris hook can actually allow you to expand one area more than the other, which is not what you can do with the Malukin ring. So, you know, I think especially for the uveitic eyes where the pupil has been stuck and adherent for a long time, and if you're not a frequent user, please use the hooks. They are so much safer to use.
Absolutely.
So there is a position for hooks even now as we speak. So a lot of us.
I think in Dr. Titiyal's practice, he does it without anything.
Most cases. But,
well, I showed you the first case. You know, I thought it was fine.
Definite indications for using hooks also, like floppy iris cases, where you proceed with surgery and subsequently the pupil constricts, there putting devices can be very difficult sometimes because you're going to
Agreed.
hook underneath structures also. In those cases, I think iris hooks are better, especially struggling with toric IOLs where the pupil constricts towards the end of surgery and you don't know where you have to put your access or toric IOLs. I find these iris hooks great help in that situation.
Agreed. Yeah.
There's a very
the thing-
interesting. Sorry.
Yes, please.
Like a little picture frame. So, sometimes you can actually move it to one side or to another side, so that you can actually focus on, say, the toric marks for an IOL. So you can still use that as a picture frame, if you had a toric implant. And Boris has actually shown his ability to suture the ring to the side where the center of the IOL, of the subluxated lens is, so that he could do femto. So that's brilliant as well. You can't do that with iris hook sticking out with femto. Yeah.
One very interesting question, and I think I'll put that forward to Dr. Partha here. Dr. Partha, if you can answer shallow chamber and small pupil. In these cases, what exact trick can we use because they are struggling with that one situation?
So remembering the fact that if it is a shallow chamber, the OVD is the first device that has to be used. So with the OVD, if the shallowness is good enough and can be improved, then the rings can definitely go in. The rings actually take up space, as Professor Chee also said. If in case the viscoelastic has not been able to deepen the chamber to a proper limit, then the hooks are again the best to be used.
Fantastic.
Yeah, in shallow interior chambers, less than maybe 2.5 or so, hooks are the preferred ones because there have been studies around in which they say that the endothelial cell loss somehow is more with ring rather than with the hooks, and they take up more space. So that is one thing which should be definitely taken into consideration.
Dr. Namrata and Dr. Jeevan, if you could answer anybody, what are the other instruments out there for small pupil management? I mean, we've seen iris hooks and Malugian ring in this scenario, but are there any other instruments and are they good enough for doing? And this is the question that has come. So.
Others are there, like there's a one which came was OS's pupil expander. Then there was yet another one, of course, from Dr. Suvin Bhattacharya.
Eye ring at some point.
Yeah, Dr. Suvin was the one who gave his B-hex ring, which has undergone several modifications as well, and which is quite good also. Only thing is, I find it a little more flexible than the other devices. So that is the only thing, but you have to get used to it, and that's also a good device. Sir would like to add something to it.
Dr. Jeevan?
No, as Rohit said, I'm not very fond of using devices, but yes, I have used Malugian rings effectively and BX also, and I thank to Suvin that he made me to look into his devices in the sequence of developments, and sometimes they are very effective and useful. And devices which are not very bulky and they are softer and they can be injected to the 2.2 incision should be used in these cases. And Suvin VX rings I've used in a shallow chamber also. It goes very nicely inside to the 2.2 and you can effectively do the surgery. So as rightly said by Dr. Partha, I think you need to get used to these devices correctly before jumping into one particular thing. One I'd like to highlight to the viewers and the audience, whenever we make a side port for putting these hooks, we have to be little careful not to do a too anterior incision for side port, because if you have a too anterior incision, that will tend the iris up and you can have more damage to the iris structure. If you are little parallel to the iris plane, that is little posterior limbal incision, that will make sure you don't tend the iris tissue. And this will be also very effective for when you stabilize the lens also. You have a little posterior incision and you are parallel to the tissue.
Last question to Dr. John, if you could answer this, sir, and then I'll move to my presentation. So if you could also make me a presenter, guys, team. Dr. John, do you perform pupilloplasty at the end of these, in these difficult maneuvers? Whenever you stretch the pupil or you're having a ring inside, sometimes the thing becomes atonic. Do you do a pupilloplasty?
I do that before I start, but when I'm done, I don't, because I think with the Malugan ring and with the iris retractor, it should be pretty well expanded. And if you're free of adhesions when the pupil comes down, it's really not a problem. So I don't do it at the end, but I do it in the beginning. It does make the putting in the Malugan ring a lot easier. Sometimes I even do a little bit of sphincterotomy as well. I do have one little advice is you can see Dr. Chee did a beautiful job. One of the things when you're struggling with everything, watch out for the anterior capsule. The last thing you want to do is cause a tear in the anterior capsule, because you don't realize that until you start doing the CCC. And then, you have problems putting the lens in and everything. So, float the iris up quite a bit with viscoelastic, and you can work on it. But really, keep your mind, don't get too carried away with the iris. Keep your mind on the anterior capsule. It's very important, because one time I actually caused a tear in the anterior capsule and it got me into all kinds of trouble.
Right. Okay. Thank you, panel. Thank you, speakers, for your presentations. And I'll move to my presentation now. Mine is on managing complications of cataract, but I'm going to talk a little bit, two different topics, and I'll just go quickly into it. One of them is a complications that I received from somewhere else. So patient was basically, he came to me with a capsular phimosis of this, like this, and a almost dislocating format. Initially, I thought I'll just, take that IOL and just glue it into place after taking out the bag around it. Came with the postoperative refraction of 2200. If you can see, that's right in the center of the pupil. That patient's not going to be seeing very well. I made my marks at 180 degrees. I've made a partial thickness flap on one side and then the other side 180 degrees apart, if you can see the flaps. Next, what I'm doing here is making a trocar AC maintainer entry to have my infusion inside. Once I have infusion inside, I make two side ports. That's it. Just two side ports in the corneal, clear corneal wound. Ensure that I'm free of any viscoelastic. I first try and remove any, take out this, nick that bag, but I was not able to do so. But so what I did is eventually went and held that optic, the optic edge. But while I was doing that, if you see on the side periphery, there is a huge endocapsular ring on the peripheral of the bag. So this owing to the fact that now I have to change my strategy, not just to glue the lens in, but also to remove that endocapsular ring in place along with the bag. So now I'm making my sclerotomies. And once I've made my sclerotomies, I'm using a modified PAL technique to kind of hold and grasp that optic edge. Once I've grabbed that optic edge in place, I'm doing a vitrectomy through the sclerotomy entries that I've made along with the limbal entries. So once this is done, I first found my part where I can grab that endocapsular ring. Now watch what I'm doing here. I'm holding that optic of the lens very, very tightly and removing this endocapsular ring. At this point, I'm feeling very proud that I've held the endocapsular ring, and now I'm doing my vitrectomy through the side port. While I was doing this, I'm also now going back and oops, I've dropped my lens inside. So this is a big problem in this case. What do I do? Sometimes fortune favors the brave. I'm actually trying to push my trocar in. If you see what I'm trying to do, I'll just show this in a replay of sorts. I'm trying to push my trocar in, but now what happens? Watch this. I'm putting my trocar in, but at the end, what's happening is infusion is actually coming out. Fluid is coming out of the main port wound or the side port wound which I had created. And that is allowing a convection current inside the eye. That's how, because it's already a vitrectomized eye now, it allowed my intraocular lens to come back into space. Now I'm grabbing this with dear hands and with kid gloves to ensure nothing happens at this point of time. Once this is done, I can externalize both the haptics, my endocapsular ring out. I can externalize both haptics. Remember, these PMMA lenses are one of the best lenses that you can glue into place. The reason why I say that is because they have a bulbous end to it, and that bulbous end kind of sticks very well into place when it goes into the haptic, when the haptic goes into the tunnel, Gabor-Chariot's tunnel. Now I'm using a vitrectomy cutter to cut off any bag remnant that is attached to any vitreous component over there. Once this is done, I really have a good round. Now I have all my bag remnants out. I'm trying to make sure that my pupil is round enough. If you don't, nowadays I also do a pupilloplasty of sorts. There was some amount of vitreous which I did go back and remove. And post that, you can actually go ahead and remove all the trocars, close that flap, close that glue, close it with glue, and this probably is the end of this. Patient was 612 post-operatively. I'm going to show you another case and then we will take all the questions as is. So this is a very interesting case as well. This was a product devised by Dr. Susan Jacob, but it found relevance even in a. So here's a case where you have a deformed bag inferiorly. The zonules are intact, and we see this quite often actually. Zonules are intact. I'm making my rhexis just like how I would. Only thing, I tend to be a little bit away from the this thing. I try to make it as central as possible. Once I've done that, I've done my hydrodissection, and it's a very soft lens, so I don't really need to use much high power. What I'm trying to show here is I'm getting away with cataract surgery even in a case of subluxation like this. Now I said to myself, you know what, I'm just going to place a lens inside, IOL inside, and see what happens. But that's not going to be enough, so I'm going to place an endocapsular ring first. So I place my endocapsular ring into the bag, and just in interest of time, I'm going to go forward, not show the ring. Once my endocapsular ring is in place, I've placed a 3-piece lens. I always place a 3-piece lens in these cases nowadays, because in case they have to be switched over to a complex scenario or complication, I can always glue that same lens in place, as I showed in the previous case. Now I'm trying to see whether this pupil, it's not centered, and I know Dr. Jeevan is looking at me and saying, boss, don't leave it like this. I'm actually ensuring to see that, you know, I'm not happy. So now what I have to do is actually ensure that I can bring that bag back into its place. So what I'm doing here is putting a glued capsular or a paper clip hook that was devised by Dr. Susan Jacob. It's by company Morcha. I have no financial interest in any of them. But here what I'm doing is making a sclerotomy under the flap, but in the sulcus space. Remember, I'm in the sulcus space, not in the posterior segment. And I've also made my Gabor-Chariot's tunnel. Why am I making a sclerotomy and a Gabor-Chariot's tunnel is because the device which I'm going to be using needs no sutures at the end. So what this does is a distal end goes and holds, I hold that distal end, and the proximal end looks something like this. Once I've externalized that distal end, I ensure that this paper clip, it looks like a paper clip, so that edge goes below the anterior chamber, anterior capsule rim. And once I've pulled enough, if you can see clearly how it was to how it is pre-operative, now I tuck that other distal end into the Gabor-Chariot's tunnel, and voila, I have a centralized IOL bag complex with an endocapsular ring. So how this helped me is without any vitrectomy, without any sclerotomy, without any infusion or any sort of vitrectomy procedure, I was able to attain a central pupil, and this is the 1 week post-operative of the same patient. Wanted to show this case because I thought this is a complication which we all might face, and how do you come out of this in certain scenarios. And I will be willing to take some questions. Before that, any comments from the panel in terms of how you would handle the first scenario? I think that's more interesting in terms of we all get those capsular phimosis and decentered bags and subluxated IOLs. So how do you handle them? I would love all the panel from starting from Dr. Jeevan, if you could start with your comments on that. I think everybody wants to know subluxation and how do you handle these subluxated IOLs?
Yeah, Ashwin beautifully shown the technique of fixing the PMMA lens. But we know that cases with uveitis, cases with pseudo exfoliation, they would have these things happening in a immediate past, maybe within 2 or 5 years down the line. And most of the time, the phimosis and the weakness of granules is going to cause bag dialysis in these cases. And nowadays, we do put CTR in cases with a pseudo exfoliation, and these are difficulties which younger people might face subsequently after 10 years or so, and that may make things difficult. So what I would appreciate the younger generation to make sure, if you have a loose granules or disease process like degenerative conditions, maybe with the knowledge of having a good results with fixations, the primary surgery can be fixation in such cases, so that we don't have to have a second procedure like this to happen, because these procedures are not free of difficulties or complications. I would advise people, especially the case you showed, that the reverse fluid current happening in the vitreous cavity, then getting the entire bag out, would have some turbulence in the posterior segment also. So towards the end of surgery, you need to assess the periphery and see if there's any point of dialysis or tear which has to be taken care of at that stage, or maybe subsequently within next 24 hours. It's must for all these difficult cases. So in my hand, I would have done a almost similar procedure. Maybe I would have taken the entire bag complex out, because I may not be very confident to fix this lens, rigid haptic lens, and shift to a routine the multi-piece foldable lens and refix those cases. And I've seen people doing retrofixation also with very good results. I have not done those cases, but yes, I would have gone for the entire bag removal, done a good vitrectomy, and gone for a scleral fixation of a multi-piece IOL.
Fantastic, thank you. Dr. John, would you want to comment on this, Dr. John?
Yes, I'm also more conservative. I probably would take the whole complex out as well and do a glued fixation of an IOL. In this situation, you can even glue a multifocal 3-piece IOL. One thing about putting that into the what you did in the scroll tunnel, the PMMA haptics, they tend to be very brittle, so they can break very easily. So you have to be extra and ultra careful. Whereas with the 3-piece, they're a little bit more forgiving. So I think that's my advice.
Dr. Chee, do you have any comments for this on this?
You showed surgery beautifully, and you handled it very well. I think I would have explanted the IOL and done a Yamani technique for intrascleral haptic fixation. Yeah.
That's it. Dr. Partha, would your comments be on this?
Ashwin, this was absolutely level 3 of difficulty in situation, because not only was there a PMMA, but it was a fibrosed capsule, and also you had the CTR in place. So removing the bag with the CTR and the PMMA lens would have been the easiest way out. Of course, you have handled it extremely well because of the expertise you have for handling these cases. But again, if one is conservative, one takes out that whole bag, CTR and lens complex, and then goes in with a fixation of a 3-piece lens, and that is a glued IOL. So that is how I would also have handled it.
Dr. Gaurav has kept quiet for a long time. I would like to ask his opinion as well in subluxated IOL. What do you do?
So Ashwin, I think you did a great job of handling it, because it requires a very tactful surgeon to actually get away with what you did. So beautifully shown, and all of us who aspire to learn these new techniques would do really well. And as the other surgeons have all mentioned, that the conservative way. So for a surgeon who may not have brilliant skills as that what some top surgeon may have, he may probably find it much easier to go back and remove the bag. But all the same, you've shown an amazing way to do it. Now, one thing which I would like to add in addition to what everybody said is that for capsular phimosis, I would suggest that for most of us cataract surgeons, typically it's those unhealthy capsules where you're almost, you're already aware that this may go into a capsular phimosis. So watch them more often in the first 15-20 days or a month. You start seeing those changes happening, like those pseudo exfoliation capsules or some of these others, and do the relaxing YAG incisions to break that phimosis in the early stage itself. That really helps, and I tend to watch on the 10th or 15th, they put a drop of cycloplegic to see that some of those patients are not getting a bit of a phimosis, and catch them early so that they don't reach the stage where you will have all kinds of circus going along inside the bag, and bag moving to one side. So I think that's another thing which we can do to prevent these situations from happening.
Dr. Jeevan?
Ashwin,
Yes.
I'd just like to
Thank you,
add
Dr.
one thing. Recently, I reviewed a very interesting procedure for these cases where you have early phimosis happening in these cases, and the surgeon had taken this patient for a femtosecond laser recapsulotomy to enlarge the capsulotomy for almost 5.5 millimeter, taken out the piece. I found that's a very interesting, and they showed that there were no significant fibrosis. So you have to pick up cases a little early, which Dr. Gaurav is saying, and you can do this procedure. Very interesting one.
Yeah, I think
That
that's
sounds very
People should done it well.
Can I just
Namrata?
add that here?
Yes,
Soon,
Dr.
Phaik,
Soon.
yeah.
Yes.
Yeah. So, instead of taking out the IOL together with the CTR, which requires a large incision, what I will hold onto the CTR and move it hand over hand until I reach the CTR begins or ends.
Dr. Ashwin, can I add?
I'll use the scissors
Yeah.
to just snip on the bag and then get hold of the CTR and pull it out of the bag. So that will reduce the size of your incision when you take the IOL out. Yeah.
Okay. Yes. Yes, Dr. Rohit, you had a comment to make?
Ashwin, can I add some? Yeah.
Yes, please.
Yeah. I think anterior capsular polishing is also a very important factor in these patients, because that will decrease the capsular contraction by all means. So anterior capsular polishing, in addition to what Dr. Gaurav has said, these are the two additional things which should be taken into consideration.
So
I'd like to add one small thing, Ashwin. I had published this technique almost 15 years back, where in smaller capsular excess or cases, especially pediatric, uveitic patient, towards end of surgery, I do a multiple incision onto the rhexis. So it makes a postage stamp type of appearance. So this increases the size as well and decreases the chance of phimosis. If somebody can read, this is a JCRS almost 50 years back. Beautiful
I
concept.
remember 15 years back, we had not drawn a schematic diagram also for this to show this.
But that's a very good concept. It gives both. It enlarges the rhexis size and decreases the phimosis because you break the circle.
Dr. Namrata, do you want to add last few comments on this question before we move on? We have a lot of questions.
I think I would do very much the same way as Dr. Chang. I would remove the whole thing and then do a glue dial for this.
Perfect. All right.
But of course, you're a gifted surgeon, so you can get away with anything.
Very nice surgery, Ashwin.
Very nicely case managed. Yeah, very nicely managed.
Thank you. Thank you. So we have close to around 500 people actually viewing on the GoToWebinar site right now, and they have a lot of questions coming forward for all speakers. So I'll just go one by one, the questions which I missed in the earlier part. So do you measure? I think I can point it out to one by one, and each one can answer. Do you measure contrast sensitivity in all your patients of premium IOL, and why, and so on and so forth? Dr. John, if you want to answer that.
Yeah, well, we do a pentacam on all our patients, and on the pentacam there is a higher order aberration and spherical aberration. Now, most pentacam actually, they advise that if your spherical aberration is more than 0.3, you shouldn't put it in. But we've put in people with 0.5, and as you know, post-LASIK patients, the spherical aberration is much worse, and they seem to do well. So I think a lot of it is pre-op preparation, like Dr. Gaurav was saying. You got to lower the expectation, and you got to tell them they're going to have halo, they're going to glare, and they really have to be quite keen on being spectacle independent.
Thank you. Dr. Jeevan, if you can help me answer this one. This is a very interesting one. If a patient is below 20 and above 70, is the premium IOL suited for them or no? And why?
I'll take it, if somebody is above 70 and doesn't have the posterior segment problems like a macular degeneration or a scar or a diabetic changes or a long-standing glaucoma, and they have a normal anatomy, yes, they are the people who will benefit best. In fact, I'll go for a more of a higher ad for these people because they'll be more of a reading and a near work. Maybe I can go 5 focal and give them a +3, +4 ad. If they have a golfing type of attitude, then maybe trifocal for these patients. But I think the posterior segment assessment and the other features should need to be checked for older patients. For younger patients, less than 20, if most of them will be maybe a uniocular cataracts like trauma or other causes. If there's a trauma, yes, other eye will be normal. In such cases, maybe trifocal will be best at today's generation, or the newer thinking of increasing the enhanced type of lens, which gives you a depth of focus and gives a near vision, doesn't compromise the distant vision, may be good for a younger generation patients. I'm waiting for a future developments of trifocal in combination with spherical aberration change in the lens in the central optics.
Fantastic, thank you, sir. Anybody can answer this question because the more specific.
Can I say something? For the younger ones, they usually have cataracts, so their vision is already compromised. They're used to the glare and the halos, and I find that if I put a multifocal IOLs, they adapt very, very quickly. They hardly ever complain because already their vision is compromised. For the elderly, I agree very much with Dr. Titiyal, but the more elderly, maybe 80 or above, most of them have very small pupils. So they already have very good depth of focus. So they may not actually need a multifocal IOL or something, So I may just put an EDOF or something, maybe in a monofocal. But be careful. I have some surgeons doing monovision on these patients. And the problem is these elderlies don't do too well when they have anisometropia. And if they fall, they're wheelchair bound, and then you're in big trouble. So, one thing I do warn is do not do monovision on these elderly patients.
Right. Thank you. Thanks for that comment, Dr. John. That was excellent tip there. How many of you have done punchorexis, and what is the setting on punchorexis? I personally have not done. I'm going to direct him to Dr. Mohan Rajan if none of us over here have done punchorexis.
I haven't done any punchorexis.
Okay.
I think Rohit can answer because
Rohit OmParkash must have done because he's demonstrated punchorexis. Dr. Rohit is not there.
Yeah. I lost the connection. What was the question? Sorry for that.
How often do you do punchorexis?
Sorry?
How often do you do punchorexis?
And what are the settings for it?
I just did it in 2-3 cases because Dr. Mohan Rajan was really talking about it. So I use the longitudinal mode in this. I use a nozzle for that matter, but I don't use the nozzle. I use the longitudinal mode. 0-degree tip is required, which is rarely available with the Alcon people, but I tried it with the 31. And then, you go with around 250 to 300 vacuum and fluoride and just go in, push the foot switch to foot switch 3 fully, and then, back. But in one of the cases, I had a problem, so I just stopped doing it. I have handy with me all other procedures. So punchorexis, by all means, as of now, I hope Dr. Mohan Rajan is not listening to me. So that is, as of now,
I think that's that is a technique specific to him.
That's a technique. In fact, Uday Devgan has described it long back. I saw Uday Devgan's videos more than 10-15 years back doing this and kind of showing it. But I think it's a very poorly controlled technique. Risk of complications is very high. I would not suggest this to any surgeon to kind of do that when we have better alternative techniques. For me today, I think femto assisted is my first choice. Even if the patient, even if I have to really absorb the cost and cut down the cost for them, I will do everything possible to kind of bring them to a femto assisted surgery. Maybe not even have any kind of income from that patient. Yet a second choice for me would be all the things that he said. But what I typically do is use good viscoelastic and go and decompress the lens from an independent paracentesis, which means if fill up the bag, fill up the AC with good viscoelastic, have a tight chamber, go in with a 26 gauge needle from a new port, new thing entering into the chamber, and puncture the bag and decompress it, and then come back and finish the excess with a side port, never from the main port. I think these are the two most important things that I would do.
Because anterior chamber pressure has to be maintained by all means. That's the most important click. And when you puncture it, at the same time, you have to, aspirate it. Because if you give some time, it will spread to the periphery. So it has to be practically instantaneous for that matter.
Perfect.
Yes. So the moment you enter it, you can just kind of keep aspirating and decompress the lens and then fill in more viscoelastic, but make sure you're not doing any maneuver from the existing ports, the main port or the side port, till you have decompressed the lens.
Absolutely right. Yeah.
Dr. Partha, one question to you would be, how do you stop bleeding during releasing a PAS or a peripheral anterior synechia when you're releasing it? Can you stop? How do you stop? What are the maneuvers tricks that you can give?
Okay, so when we are removing the PAS, so there is definitely going to be bleeding. We need to be prepared for that. So filling the anterior chamber with viscoelastic, high molecular weight viscoelastic is the only way, and it works quite well. And once this has to be replenished time and again, and once it is replenished, if it is torrential bleeding, that means that something beyond the PAS has occurred, and maybe there's been an iris dialysis. But usually with the high molecular viscoelastic, it stops. If it does not stop, and if it is coming in gushes out, then again tightening the anterior chamber and waiting a little time for it to stop is what we need to do.
Also, you can put intracameral adrenaline. I mean, that also kind of
reduces.
may stop bleeding, and also, if you put air bubble there and you allow it to sit for some time there, then that also kind of takes care of bleeding.
Fantastic. Thank you, Dr. Partha. Thank you, Dr. Namrata. One question more, which I will take. I think this is more towards me, and then I think Dr. Chee, if you can answer this as. Do you use prior pars plana vitrectomy in shallow chambers? If yes, what are the parameters you use? So I'd like to mention that I had published this for not just shallow chambers, but for most cases where you have aqueous misdirection or any kind of positive pressure. It is called as vitrectomy assisted phaco, where we're basically doing a dry vitrectomy for less than 6 to 7 seconds. I know the risks involved in it, and I know that I'm very comfortable in the vitreous, so I can do it. I would not recommend somebody from an anterior chamber person to probably do this, but it's worked very well for me, not just in these cases of shallow chambers, but also in cases where you have intermittent cataracts, where you have coloboma cataracts, during the case where the saline is going behind and hydrating that vitreous, making your positive pressure more. We've all done iris hooks, we've all done rings, we've all done capsule tension rings, but honestly, they are not the cause. They're not removing the cause of the problem. The cause of the problem is behind the lens, and the minute I started approaching it from the back, putting a trocar and just doing a 7-second vitrectomy at 1500 cut rate, it elevates all my problems. Instead, it makes it so much easier. I get a clear cornea because I get a nice deep chamber now. Only thing, do not do it for too long, and do not do it if you have a thick black cataract or a white cataract where you can't see your port. You must be able to see your port. That's the only advice that I would give. Dr. Chee, if you could
Ashwin is also advocated in phacomorphic cases where you have phacomorphic glaucoma, and this was a paper which was published by Dr. Tanuj Dada from Opti Center, where he's done pars plana vitrectomy just prior to doing these cases, so that your chambers become a little deeper.
Okay, so I think first of all, I clarify I'm an anterior segment surgeon. But anterior segment surgeons can also learn these approaches, right? Because it involves the cataract. So I do encounter cases of phacomorphic glaucomas, especially when you have also lens subluxation due to weak zonules. Right? So the lens can be really very anterior, and in addition, it can be extremely thick. All right, and patients who are post-angle closure glaucoma, they don't come to you until they're, we see lenses that are over 6 mm thick. And so if you want to do this, first of all, you have to look at the axial length. Now, you don't really want to do this in an ophthalmic eye because you don't know where the pars plicata, where the pars plana is. But in a normal axial length or slightly short axial length eye, it would still be safe to do. And I like to use a trocar cannula, although you can do it just by reflecting the conjunctiva and using a MVR blade and go in. But what I want to suggest is that instead of going straight to the center of the globe like what we have often been taught, I always aim towards where I imagine the optic nerve to be. Because very often the cases that I encounter that require this maneuver are in cases where they are really very, very white cataracts, and I have no view of the back of the eye and where my trocar is really. So I just aim towards the optic nerve, and I think it's still fairly safe. It would be good actually if you had a UBM to see exactly where the lens is, right? How thick it is, so that you know where to aim before you do the procedure. And how much to remove? Okay, first of all, the cut rate would be between 1,000 to 2,000 cut rates. You can use a 25 gauge, although mostly I've been using 23 gauge retractor, about 300 mmHg for vacuum. And how much to remove? I put my other finger on the globe, and I'm exerting gentle pressure. And as I cut, I feel the globe. All right, and I palpate it with my other finger to see whether the pressure has softened and whether I would be able to deepen the chamber. Now, if I've stopped doing the vitrectomy and I find that I cannot adequately deepen the chamber and put in enough viscoelastic to do the surgery safely, I can always go back to that trocar cannula there and reinsert and cut a little more. All right, but the problem is that if you've cut too much and you have zonular weakness, all right, when you put in your infusion, your lens will be really deep into the eye, and well, not all is lost. You can always go back to that trocar cannula and refill with some BSS. And if you do have misdirection of fluid during the procedure, you can again go in and take some fluid out. And if you're doing a procedure, say you're trying to put a needle in because you want to fixate, your loose zonules, and you need to firm up the eye, it's not a good idea to keep pumping viscoelastic in the front of the eye. What I do is I put BSS through that trocar cannula to firm up the eye from the back. So it's very useful to have a trocar cannula, not just a sclerostomy, to control exactly where the lens position is going to be. It's going to make it useful for whichever procedure you're taking on.
Sure. Thank you very much, Dr. Chee. That was excellent few tips that you've given there. I think we have a couple of more questions, 2 more questions, and then we'll close this session. But unless somebody wants to make another comment or something. But I think it's a very interesting question. Dr. Rohit or anybody can answer this. How can we know that an Argentinian flag sign goes to the posterior capsule? What is the signs to denote that, and what do you do in those scenarios?
Yeah, well, that's the flap motility sign. So if it happens to be, what has happened is this has been there right from the day Kalman started phacoemulsification, because then the capsular axis was not there. What I'm trying to put forth is that we have been focusing only on the phaco probe or the IA tip. So you just have to widen your vision and see what the type of the flap is. If by any means the flap is everted and fluttering, this means that it is pre-equatorial. And the moment it goes beyond and becomes a wraparound tear, in other words, it becomes a post-equatorial tear, it stops fluttering and becomes inverted. So this appears much before the classical signs of posterior capsule rupture. So that is the end point where you should inflate and convert, and that is how we come to know the extent of the Argentinian flags. Argentinian flag sign, Argentinian flag, for that matter.
Right. Dr. John or Dr. Partha, anybody, if you can answer this, please comment about subcapsular dissection of fibrotic capsule.
On the what dissection?
Subcapsular dissection of fibrotic capsule, of a fibrotic capsule.
Yeah, how to dissect a fibrotic capsule?
In the subcapsular.
Subcapsular dissection.
Yeah.
Presumably it's under the anterior capsule, right?
I'm thinking under an anterior capsule, of course.
Yeah, I think you use like forceps, very fine forceps. Obviously you fill up with viscoelastic, and you go behind and you grab on where you think the fibrosis is, and just gently tease that and see if you can, I don't actually dissect it. I actually gently pull it, but radially in towards the center rather than to the side or off. That way you could tear it. but then you don't want to pull too hard because you may break the zonules.
Yeah, Deepak Magur has come out with a beautiful presentation. You know what he does is with all these plaques, he takes a dissector and goes beneath it, beneath the anterior capsule, and tries to create a plane. And then he dissects it. He uses a bimanual forceps for that matter and holds it and just spears it. Dr. Chee has, really, Dr. Chee, these fibrotic ones, they usually do not extend to the posterior capsule and beyond. So I think phacoemulsification can be continued in such cases, but dissection and using, bimanual forceps can help to take it. And you can use visco also to go beneath where you create a plane, you take a visco cannula and inject. So that will also further help to do that.
The other things you can do is femtosecond laser, increasing the energy for the capsulotomy. And of course, if there's, you just cut through the capsule and then you leave the strand, you can just use intraocular scissors and just snip it out.
You don't have to remove the fibrosis. Yeah, you can actually just cut around it.
Exactly.
Right.
Yeah.
Dr. Namrata, last question, and we'll close it from here. Role of multiple sphincterotomies for very small pupil. Do you choose multiple sphincterotomies or iris hooks? Which direction do you go and how?
Multiple sphincterotomies would be the last choice, and I have not done it for years now, although a long time ago we used to say that as an option. But if you have a small pupil, best is to use nylon hooks, and before that there's always a membrane on it, so that can be removed. The Osher's membrane, you can try to remove that. But even if you use the nylon hooks or any of the device which dilates the pupil, and when you actually remove it, then it kind of never comes back to the same meiotic size as it was there previously, because the devices would have, slightly enlarged or stretched the pupil without you having realized it. So it will never come back to the same pinpoint 1 millimeters because it would have stretched because of the nylon hooks or because of the Malugan ring, etc. So with the availability of these good devices, I don't think sphincterotomies is a great idea, because once you do it, then even phaco becomes a problem, and then the tags of the iris keep coming onto the phaco or the eye probe.
Ashwin, can I chip in with something here?
Yes, please.
Yeah, so what Namrata said is absolutely right. That would be the last resort. And typically, in eyes with a very, very tight, small pupil, which is really rigid, I would not go with one of the rings, actually, because it's sometimes difficult and the stretch will be phenomenal. I would go with iris hooks, get a little bit of a, dilation first, and then gently kind of tug on each hook at a time, like 4 hooks, and, gradually try to get a pupil which is not too large. Don't aim for a very large pupil. Aim for a mid-sized pupil, which is just enough for you to get in, like a 4 mm pupil is good enough to actually do your surgery. That way you are going to damage all the sphincter and have a big pupil later on. And the rings are probably not a great idea in such situations where you are expecting a very tight or a rigid pupil. Iris hooks with a moderate dilation is good enough, I think.
Right.
Can I just chip in?
Yes, please, sir.
Yeah. So Professor Chee showed a very nice way of very elegantly doing a small pupil rhexis, a small pupil management. So the peeling of the membrane on the pupil will definitely damage some amount of the sphincter. And if it is a very small one, like what Professor Chee was dealing with, the possibility of supporting with another Y hook while the peeling is going on is very important. So that gives the counter effect or the counter traction onto the movement of the peeling of that membrane. So that becomes, once that is done, then usually these uveitic pupils open up to 5.5 even, and then adequate viscoelastic, it stretches out a little more. And these pupils usually will not shrink at all during the course of the surgery, which is different from the atonic pupils or the ones with the IFIS.
Perfect. Thank you, everybody. And I wanted to close this session with, first of all, thanking my panel, Dr. Namrata, Dr. Partha, and Dr. John, for being here, for being present, and completely being with me full time. My speakers, very, very important, Dr. Gaurav, Dr. Rohit, Dr. Soon, and most important, Dr. Jeevan for chairing this session and helping me in organizing this session. I also wanted to end with ISRS is going to be having another webinar very, very soon on 5th of May on demystifying phakic IACLs, and John Chang and myself will be the moderators there. And he's also speaking in that ISRS session. We also have Dr. Bob Maloney from US and Eric Mertens from Belgium. They'll be talking on different topics such as phakic patient selection, sizing of phakic IL, phakic ICL implantation, to know more, and complication and managing these challenging cases. To know more of this, please just follow me on Instagram or YouTube or any of these channels, and I'll be happy to share more information on this personally. But please be there 5th of May, 9 p.m. India time. And you can calculate that in your respective countries, guys. Thank you everybody for being here. Namaste is the new hello. So here you go. Namaste.
Thank you, Ashwin. Thank you,
Thanks, Ashwin. Thanks, everybody. Thanks, John and Chee and Partha and
Thank you. Great
Namrata.
talk. Yes.
Thank
Thank you.
And Zeiss as well for helping us organize this. Yeah.
Yes,
Yeah, sir. From Zeiss side, I would like to thank all of you, sir, for accepting our request, and especially to Dr. Ashwin for helping us and being patient with us in conducting this webinar. And we would like to do more with you again. And so thanks to all the panelists, and we thank you for your valuable discussions. And the audience, as I can see the questions, there were a lot of questions, so it was really the 50-50 webinar which it was planned. So a lot of audience question got answered, and thanks to all, and be safe, and again namaste to all.
Thank
Stay safe,
you.
guys.
Thank you.
Love you
Bye.
all.
Bye-bye.
Bye.
Bye.
Very well conducted, Ashwin.
Yeah.
Very good.
Great job, Ashwin. Take care, guys. Bye.
Congratulations.